This lecture is looking at schizophrenia, and it is a psychosis that's widely recognized. In fact, as we're going to see in the notes, most people, when they think of psychosis, they think of schizophrenia. As we know, other disorders can induce a psychosis, but schizophrenia does stand in a place of its own. So if we take a look at our notes, you will see some of the demographics that we have for schizophrenia. It really, approximately 3 million Americans a year are affected with schizophrenia. The incidence seems to be higher in urban populations and in small ethnic groups, with some pointing to racism and discrimination as playing a role in the development of schizophrenia. Also, interestingly enough, those who are born or live in the Northern Hemisphere tend to have a higher incidence of schizophrenia. There are over 300,000 acute schizophrenic episodes annually. Now, by acute, we're talking about episodes where somebody needs to be hospitalized. It is a really an episode in which the symptomology is so extreme that the individual is not safe on their own and they need to be hospitalized and given medication to help relieve some of those symptoms that they might be experiencing. Between 25% 50% of schizophrenics reportedly attempt suicide. That is crazy high. 50%. That means 1 out of almost 2. So even if you go down to the lower estimate of 25%, that is still extremely significant. And 10% succeed, if you call it success. So it's really important to acknowledge the fact that there is a lot of distress that accompanies this particular disorder. There's a tendency for males to manifest the disease at an earlier age and to exhibit more typical positive, and we'll talk about positive versus negative symptoms later, and severe symptoms with poorer outcomes. The onset of schizophrenia is typically sometime between late adolescence and early adulthood. Tends to be between the ages of 15 and 24 in males and between the ages of 25 and 34 in females. But in retrospect, there may have been signs in childhood that include lack of eye contact, clumsy movements, social withdrawal, and delayed language learning. Now, I want you to think just a moment about those symptoms. And if those symptoms present in early childhood, think about what other disorder that child may be diagnosed with. And if you're thinking about autism spectrum disorder, you're right. So rarely, schizophrenia may develop before the age of 10, first with negative symptoms, and then with hallucinations and delusions, which are considered to be positive symptoms. So we're going to get to those different symptoms and how we categorize them coming up right here. So as the clinical description of schizophrenia is a disturbance that lasts for 6 months or longer, including at least 1 month of delusions, hallucinations, disorganized speech, grossly disorganized or catatonic, not moving behavior, or negative symptoms. So delusions are extraneous beliefs involving the misinterpretation of perceptions or experience. Okay, that's the technical terminology for delusions. Hallucinations, interestingly, may occur in any sensory modality. Lots of times people think they're only visual, but that is not true. Auditory hallucinations are actually the most common, and we do call them hallucinations. Positive and negative symptoms of psychosis. That's what I mentioned before. I want to get to here. To have a positive symptom in the clinical diagnosis of schizophrenia, we are talking about an excess of normal functions, behaviors that are there but should not be absent, or they should be lessened. So it's not that they're woohoo, these are great symptoms. It's that you have too much of something, or you actually have the presence of, for example, hallucinations that you should not have. And here is just a list. I tend to have a difficulty with a couple of them, but we'll get to that. Delusions, hallucinations, disorganized speech and or behavior. That should not be there. That's a symptom that's present. Distortions or exaggeration in language and communication, agitation, and catatonic behavior. Catatonia meaning being in this physical state of being where you're not moving. It looks as though you're not responsive at all to the environment around you, and you do not respond to the environment around you. Catatonia. So if you look at catatonia or catatonic behavior as a thing that is present, then it certainly is a positive symptom. Sometimes it's hard to imagine that way because you're like, well, they should be behaving, but they're not. They should be responding, but they're not. And so that's why it's easy to think of it in terms of negative symptom, but it is classified as a positive symptom. So what are some of the negative symptoms? Diminished or lack of normal functions that include affective flattening, mean not much emotional expression. You could say something horrible just happened. Okay, that's what it is. Flattened affect. Inappropriate emotional expression, perhaps laughing hysterically at something that you should not be laughing at. Emotional withdrawal, poor rapport, stereotyped thinking, lack of spontaneity, being able to respond in a spontaneous manner to interactions with others or in conversations. Attentional impairment, not being able to focus on certain things, or in some cases, anything. Alogia, important to remember, alogia, restrictions in the fluency and productivity of thought and speech. A or an means away from or without at the beginning of a word. Avolition, here's another one. Restrictions in the initiation of goal-directed behavior. So you don't have goal-directed or behavior or initiation of those behaviors. And finally, anhedonia, or lack of pleasure. We've talked about that several times before. Any combination of symptoms may be present. So you're not going to necessarily see each of these symptoms in every patient. I hope you will take a moment right now. I have a short video here that shows 4 different patients and the way that they present with symptoms of schizophrenia. So take a moment, click on the link, and go there. And I'm waiting right here for when you get back. All right, here I am. And if you didn't watch that, I'm telling you it's interesting. So etiology, what is it that prompts the development of schizophrenia in an individual? First, there is a genetic component. The risk for inheriting schizophrenia is about 10% in those who have one immediate family member with the disease. There is a 40% risk if both parents or a twin actually has schizophrenia. And human chromosomes 15, 13, and 8 each seem to be implicated in specific situations. Not all three necessarily at once. Please don't, I don't want to misrepresent that. But these are three different chromosomes that have been linked significantly with individuals who have schizophrenia. And we're going to, the different genes seem to be involved depending on ethnic origins in addition to that. So the defective gene may cause autoimmunity. And later, when we're looking at some of the theories, we are going to come back to that concept. So remember that little point there. 41 genes coding for growth factors that affect the development of glial cells. Remember the glial cells, not the neurons, the glial cells are associated with schizophrenia. And one thought is that viral infections may further weaken glial cells, resulting in faulty synaptic communication. Remember, glial cells have turned out to be much more important than initially they were recognized to be. Initially, it was like, oh yeah, there's stuff here so the neurons can lay there and have support and do their thing. But now we know that glial cells do contribute to neuronal communication in some cases. Other potential contributing factors include an increased incidence in those who had mothers with complications during labor and delivery. It could be prolonged labor, lack of oxygen, damage when one is going through the birthing process. Also, those who had a short gestation and were born with a lower birth weight than typical. Those who had experienced oxygen deprivation during fetal development or perinatally, right before birth and after birth. Those whose mothers had less than 1,000 calories a day during the first trimester seem to have a higher than usual incidence of schizophrenia. And those who were born in the winter months. And this is one thing they started looking at. They recognized this quite a while ago. And very often, the mothers were actually in their second semester during a major flu epidemic. And of course, you have an immune system that mounts a response to the flu. You have abnormalities in physiology and neurochemistry for a while during the experience. And could that have prompted the development of schizophrenia? Viruses have been proposed, retroviruses have been proposed. Interestingly, childhood abuse. This is still out on, this has not been confirmed, but there is evidence that there's a high association with the auditory hallucinations in children who were abused. And an increase in paternal age seems to be a risk factor for schizophrenia in the offspring. And this is another interesting point because for so many years, it was only the mother's age that was implicated in the development of certain childhood disorders and long-term disorders. But here we see this particular relationship, which is important. And again, I know I brought this up in a couple other classes, but I do this for a reason, that not every infant who experience some of these different circumstances will end up with schizophrenia. And I am one of those. My mom lost weight, significant amount of weight during her first first trimester. And she had such bad nausea and she vomited and she was taking in far less than 1,000 calories a day and keeping it in. And so I also was born placenta previa, which means the placenta came first and the umbilical cord also was starting to rupture. I was without oxygen for basically that entire birthing process after that point. And so I was extremely oxygen deprived. And so there were a couple of things that definitely can contribute to the incidence of schizophrenia. I am so grateful that I do not have that. And the reason, again, that I bring it up is I want to make sure that people don't get the idea that if these things happen, oh boy, you're going to have schizophrenia as an adult. That is not, these are risk factors. Okay. The diastasis, that's a hard one, stress model says that you have a genetic predisposition or to heightened sensitivity to stress. So just genetically, you are going to be hyper sensitive under any circumstances that induce a stress response. And you take that and then you add to that an environmental factor that can predispose one to schizophrenia. There's also a traumatic neurodevelopmental model. And this model has evolved because there's been enough evidence in many cases in which there's similarities between effects of traumatic, I really wrote this poorly, didn't I? Between the effects of trauma, let's put it that way, on the developing brain and biological abnormalities that are found in the schizophrenia patients. And I cannot tolerate that. So I am going to change this right now and get rid of this. There, that feels better. And finally, here's that autoimmune model. And that is that one has auto antibodies. And move back up to earlier in this list where I mentioned the association with perhaps some autoimmune issues. Here, a defective gene may cause autoimmunity. Okay. Here is an article that actually speaks to that. Even if you just read the abstract, I think it will be useful for you. I think it's important information. And I want to emphasize right here, it is not due to a bad mother. Oh my goodness, for so long in the early days, post-Freud a bit, it's like a child has schizophrenia because their mother was a, go away, I don't want you. Oh, come here, I love you. Go away, I don't want you. Oh, come here. A bad mother. Different types of characteristics were described. This is not proven to be true. Now, here again, if we were in the classroom, I would be standing there watching this video with you. There are a couple of parts. Please at least watch this first, Gerald part 1. I hope you'll watch both. Gerald, oh my goodness, these are oldies but goodies in the terms of showing what schizophrenia can be like. Gerald presented with practically every single one of the symptoms at one point or another in his life. It's sad, but it's very interesting. And I think it's important to watch this and just note the interactions and the attentional things and the misinterpretations and the delusions and the hallucinations. Please take a few moments to watch this YouTube video, and I'll wait here for you. And again, when you're done, click back on and we'll go back to start with the categorization of schizophrenia. Okay, I wish right now I could have a conversation with you about Gerald. this is one of the biggest things that I miss about not being in the classroom, is the interaction we would be having. And I know if I was holding all synchronous class meetings, we might be able to do that. But in my experience, the Zoom interaction is far different from the classroom interaction. But I hope you learned something from watching this video and developed and gained a greater appreciation for the symptomology that can be observed in one who has schizophrenia. Okay, next, categorization of schizophrenia. First, we have type 1. And type 1 is characterized by predominantly positive symptoms. Remember, positive symptoms are those symptoms that are present. They're things that are present, behaviors that are present, but should not be, or they're present in excess. Okay? And this type 1 tends to have an acute onset, a fairly good prognosis, and a favorable response to neuroleptics. Remembering that neuroleptics are drugs that block the availability or actions of dopamine. Type 2, on the other hand, is characterized by predominantly negative symptoms, that absence of normal behaviors. That list, go back and check that list if you want to remind yourself. And in the type 1, it's generally the dopamine dysfunction, and type 2 could be dopamine dysfunction, but other things going on as well. There tends to be chronic affliction with this. There's a poor prognosis to type 2 and a poor response to neuroleptics, which is an indicator or an indication that there are some other neurotransmitter or other neuroanatomical abnormalities that are the cause. There is cognitive impairment, and if one looks at the brains of these individuals, there's atrophy of the cortex. Okay. Many patients, however, are a mixed type, and it may be that there's a continuum. So at one end you have, tons and tons of positive, extreme positive symptoms. The other end, all negative. And somewhere along the way, you get some negative, some positive mix, okay? So when we're looking at neuroanatomical abnormalities, what do we see? Okay, ventricles are on average 40% larger than ventricles that are seen in normals or individuals who do not have schizophrenia and otherwise have normal brain anatomy. This is not good. If you have bigger ventricles, unless you have a way bigger head, it means you don't have as much brain volume. The actual brain tissue, neurons, glial cells, etc., are reduced or tightly packed. And that seems to be the case with schizophrenia. The number of neurons seems to be normal, but they're deeper in and they're packed more tightly than they should be, which impedes neuronal transmission. So a smaller cerebral cortex, less gray matter or neurons, smaller temporal lobes, smaller limbic region, loss of neurons in the thalamus and cerebellum. Think about that in terms of information coming in, sensory information and motor information going out. Signs, there are also signs of abnormal structural shape and an asymmetry in the brain. So those are some of the neuroanatomical abnormalities that have been observed. Now next, there seemed, back in around 2002, there started to emerge articles about a mystery particle in the cerebral spinal fluid of patients with schizophrenia. and it was an unknown particle. It was larger than a virus, but smaller than a bacteria, seemed to be similar in size to a prion. And here I have actually a link directly to a very brief report about this back when it was initially being investigated and observed. And you see, I go, but in 2003, oh no, we didn't see that in these. So I gave you a link to literature that, an article that talks about that. But later on, somewhere around 2012, it's like, guess what? There are these weird little particles going on in the brains. So it is still an ongoing journey of investigation. Okay, so what are some of the neuropsychological and neurophysiological abnormalities beyond what we've just seen? Usually, when there's testing, there's very low blood flow to the prefrontal cortex, that executive functioning area. And if you do an EEG on a patient with schizophrenia, it shows this P300 response that is delayed. It comes later than it should and weak. And what is the P300 response? It is a positive electrical spike going up that occurs about about 0.3 of a second after a stimulus that is unexpected or a stimulus that's relevant for action. This is before you actually consciously recognize that stimulus. And I wanted to get my glasses on so I could see this to describe this to you a little bit. Here is actually an EEG graph, or a graph developed from an EEG that shows how you should be. Here's the stimulus right here. And you should be getting this peak much sooner than this. And the average latency is here, but in the case of schizophrenia, it may be right here, this last one, okay? So that's a little bit of an example of that. Also, the left temporal dysfunction seems to be particularly implicated in this P300 response that is delayed and weak. So if you look at that on both sides, both hemispheres, you're going to see the left dysfunction to be increased. All right, look at the list I've got going for you here. Biochemical changes associated with schizophrenia. First, there are decreased dopamine metabolites in cerebrospinal fluid. So there's something with the metabolism, the metabolic breakdown perhaps of dopamine. There is also an increase in the number of D2 receptors. Those are the postsynaptic receptors in the striatum, which is an area of basal ganglia, putamen, caudate nucleus. Also a decreased expression of D3 and D4 messenger RNA in specific cortical regions. That would explain reduced cognitive function. Also decreased cortical glutamate. We need glutamate to go up there and get our neurons going, oh yes, we should talk to each other, let's talk. And if you have less than that, you're going to disrupt a lot of neuronal communication that should be taking place. And remember, upregulation, not enough cortical glutamate. Oh gosh, we've got to build more receptors. Let's build more receptors so we can be activated by the little glutamate that's out there. Remember my baseball field and baseballs example. There's decrease in glutamine uptake sites in the cingulate cortex. We've talked about the anterior cingulate before. Decreased messenger RNA for the synthesis of GABA. Oh my gosh, so far we have dopamine, we have glutamine, and now we have GABA. All right, so we don't have enough GABA, so we end up with more GABA binding sites in the cingulate cortex. So there's something going on with that too. And if you look at, think about what those different neurotransmitters do, and then you look at positive and negative symptoms, you can start mapping on to some of those biochemical abnormalities. So here's a beauteous picture that I put in here, the biological basis of the positive psychotic symptoms. It is thought that overactivity of dopamine neurons in the mesolimbic, midbrain, limbic, VTA to limbic areas, dopamine pathway is involved in that particular, the expression of positive symptoms. And this is just, here you see the amygdala, you see the hippocampus, here's the VTA where you have the dopamine neuron cell bodies living and going up here. And so you see we have excess, we're reaching out here, and then now we've got some information going here and here, and now we're changing up the structure the way that it should be. Now, when the pathway is turned on by schizophrenia, drug-induced psychosis, mania, depression, or cognitive disorders, it doesn't matter which one, the result is the same: delusions and hallucinations. Now remember how even in severe depression, farther in, that there can be hallucinations and delusions in depression, and also in mania, clearly in psychosis. So if we block those postsynaptic dopamine receptors, specifically in this pathway, those are the D2 receptors, you're going to diminish those positive symptoms. And all known antipsychotic drugs that reduce positive symptoms block these receptors. And again, particularly the D2 receptors. Now, the atypical neuroleptics are much more specific. So that is important. We'll probably be looking at that difference in a moment. There also can be glutamate GABA dysfunction, that ratio. And again, it's very hard to determine exactly what's going on in these certain cases, because it's hard to gather this. Each individual may be different, and depending on what's more predominant, positive, negative symptoms, there can be differences. So, biological basis of the negative symptoms, those behaviors that should be there but are absent or very limited. There has been, as far as I know, continues to be a debate and regarding these negative symptoms. Okay, and it is in some schools of thought say mesocortical dopamine pathway is involved with the negative as well as the positive symptoms, and blocking dopamine activity here will reduce the negative symptoms versus the conventional neuroleptics, which are not useful and may even produce more negative symptoms themselves. Remember, the cognitive side effects of neuroleptics can be a suppression of cortical activity. Remember, we talked about those 4 different dopamine pathways. If we reduce dopamine activity in each of those 4, you're going to end up with suppression of dopamine in not just the mesolimbic area, which contributes to the positive symptoms and the emotional aspect, but also the cognitive, right? And so if we do that, and you lower the activity of cortical neurons too much, you can end up with this cognitive side effect called neuroleptic induced deficit syndrome. You please know that I'm going to be making sure that you know what that means, okay? And here again is a reminder of these pathways, just so that you don't have to refer back, and maybe a little reminder. But this the most common thought in terms of the negative symptoms is that you don't have what you need up here. You don't have the dopamine or the glutamate, or you have a glutamate and GABA dysfunction. That means you might potentially have the wrong ratio of one to the other. Okay, let's move on now to the drug treatments for schizophrenia. You had this in your homework, and so hopefully a little of this will be familiar, but conventional antipsychotic treatments are the neuroleptics. And going back in history, in 1950s, throughout that decade, chlorpromazine was thought to be an antihistamine. But while it was being used for an antihistamine, which it actually didn't help, it didn't function well, it was observed to have antipsychotic effects. And so when used in somebody who showed psychosis and they were being treated hypothetically with chlorpromazine as an antihistamine, they showed a reduction in psychoses. Also, these also have effects at alpha adrenergic, okay, norepinephrine, and muscarinic cholinergic receptors. So you end up with unwanted side effects. They're not good. They're not good. And in the 1960s and 70s, it was determined that all neuroleptic agents did block dopamine receptors. Again, hopefully you won't forget this, because I brought it up like 3 or 4 times now. And you're like, really already know this, particularly D2. And examples include haloperidol, Pymazide, and chlorpromazine. Those are 3 examples. Now, atypical antipsychotics became developed, and this was huge because they were selective and are selective for mesolimbic dopamine receptors. And that means they block dopamine activity in that circuit that is the cause for delusions, hallucinations, and the other positive symptoms in large part of schizophrenia. Now, clozapine is in a class all by itself. It is, sorry about this, sorry. It has atypical properties, meaning it doesn't interact with every single dopamine pathway. And it is more effective than typical neuroleptics in some patients. It is one of the most complicated drugs in psychopharmacology, however. It has notable interactions with at least 9 different neurotransmitter receptors. Talk about unwanted effects that might accompany any of the effects that we're looking for to reduce symptoms. And here's the final kicker for clozapine. It can cause a potentially fatal bone marrow toxicity known as agranulocytosis. Don't want fatal bone marrow toxicity. So we always look for the best choice that can help control symptoms with the least number of negative side effects or potential lethal side effects. Lastly, here I have risperidone, and this is one of the more newly utilized drugs. And in earlier studies, and to the best of my knowledge, still continuing, if you compare it to haloperidol, Haldol, you have 1/2 of the relapse experienced after 1 year. So that's good. It does have potentially serious side effects, again, that need constant monitoring. So I put more dopaminergic pathways here. I just want you to get very comfortable with those. They're so critical for so many different things. And let's talk about the problems related to those conventional neuroleptics, which I've already mentioned, many of them, but we're going to add a couple more here. Remember that with conventional neuroleptics, we have the blockade of dopamine receptors in all 4 systems, all 4. There is something called extrapyramidal reactions, EPRs, that result in times because of blockading receptors in the basal ganglia. Remember, the basal ganglia are involved with movement, particularly initiation of movement. So essentially, it's a drug-induced Parkinsonism. Boy, I'm really having trouble talking tonight. It's like Parkinson's disease, but it's induced by this drug. How's that? Thank you for hanging in there with me. Like I said, I'm just pretending this is class and those things happen. So anyway, another potential problem with the use of conventional neuroleptics is tardive dyskinesia. I have seen recently that there's ads for this on TV addressing this particular problem. And it means slow, faulty movement. It includes facial tics and gestures such as lip smacking, tongue protrusions, and hyperkinetic movements. And this develops because of a long-term blockade of those nigrostriatal dopamine receptors by conventional neuroleptics. The postsynaptic receptors, again, here comes that upregulation concept. We're cutting back on how much availability of dopamine they have, right? So now they're like, oops, not much dopamine out there. We need to upregulate receptors. Let's build some more receptors. And now you're going to have this extra problem with more receptors trying to, they're not trying to, but being up there for activation by what dopamine is available to them. And unfortunately, this particular thing can be irreversible. If we block dopamine receptors in the mesocortical dopamine receptors system, in the mesocortical dopamine system, going from the midbrain to the cortex, you worsen negative symptoms or produce that cognitive blunting that I mentioned before. Okay, so include that as a problem. Blocking dopamine in that little itty bitty tuberoinfundibular pathway that's by your pituitary and hypothalamus, that can lead to inappropriate lactation in women. That is referred to as galactorrhea. Rhea means flow, by the way. And finally, we can end up with the use of conventional neuroleptics with something called neuroleptic malignant syndrome. This is a rare syndrome, which if you get it, it doesn't matter. It's like if it's 1 in 100, guess what? You're that one, right? It's rare, but potentially fatal complication. And it consists of extreme muscular rigidity, a high fever, ultimately coma, and eventually death. So I hope that this has given you a little bit more of insight into the various symptoms that we see in individuals who have schizophrenia. I do hope you watched the video links that um, I embedded in these notes, because they're not waste of time videos. I don't think. I think they'll be useful in terms of gaining a fuller understanding about how presentation can be in individuals with schizophrenia. And I'm going to be putting up some notes on schizoaffective disorder, baby notes. Just give you some facts about that, where it is different from schizophrenia, but it's also associated with it, and in that same kind of group of disorders. So thank you for watching this, and hope it helped, and I will see you again soon.